and get started. Welcome everyone to MILI-sponsored COVID-19 student research presentations. We have here 3 students and their mentors, and I will start with a little bit of a background of our program, and then we will have our presenters go and share their research with us. Of course, no need to say how much of a crisis the pandemic has brought to our lives, and it affected all sorts of the aspects of our life, including lots of internship opportunities, research opportunities that our students could have in the industry. But we were resilient with it, and we, as MILI, we work with the students, our affiliates, and our Carlson School colleagues to actually put together a research program to support our MBA students this summer. And we partnered with different organizations, including in this presentation, you'll see partnership with Health Factors, as well as the University of Minnesota's Bakken Medical Devices Center. So our students have worked on various different types of projects, and we are presenting 3 of them today. Without much more explanation, I'm just going to introduce our very first speaker, James Burzynski, who's a PharmD and a part-time MBA student. And James partnered with the Carlson MBA alumni, Paul Hines, who's a co-founder of the Health Factors on a project with Ambient Intelligence, multisensor monitoring of patients to improve care delivery during COVID. Just a background on James. James graduated from Midwestern University Chicago College of Pharmacy with a Doctor of Pharmacy degree in 2008 and has over a decade of healthcare experience. He worked in several clinical settings, including as a consultant, pharmacist for long-term care services, and working as an ambulatory care pharmacist for an anticoagulation clinic. In addition, he has worked as a clinical reviewer for a pharmacy benefit manager in the Twin Cities for 2 years. James started at Carlson in January 2019 with a focus to gain experience on the business side of the healthcare industry. During the fall of 2019, James was selected to the MILI Fellowship Program and worked alongside cross-functional team to evaluate medical innovations for investment potential. He's currently consulting at a medical device company and working as a hospital pharmacist as well. He's looking for his next big challenge in healthcare space as he plans to graduate from Carlson in the spring of 2021. And he currently lives with his wife and 1-year-old daughter in Sioux Falls, South Dakota. I also want to say a few words about Paul Hines, who is an MBA from Carlson School of Management with finance and MILI specialization. He's a MILI fellow. He's a member of the MILI sub-board, and as well as a member of the MILI affiliates board. Paul is the co-founder of Health Factors, also the co-founder of Respiratory Sciences, the Health Factors subsidiary, and board of advisors at Ambient Intelligence. Lots of really interesting ideas that we will hear from James. So James, why don't you take the presentation? Thank you. And please send questions on the chat box, and we can ask our presenters at the end of their presentations. And then we will move on to the second and third presentation. The second one by Arijit Chanda, and the third one will be with Matthew Stanovich. Okay. Thank you, James.
I'm going to go ahead and share my screen. All right, we good? Can we see that? Everyone see that? Great. All right.
We're also seeing the notes page. James, I think you had a way to just show the presenter view without the notes page before.
I did the same thing. Hold on a second. Let me stop sharing.
Perfect.
Hold on just a second.
And yeah, and I think you have to click on the presenter view now.
That's what I'm trying to do.
Perfect.
Oh, hold on. Still, it's not letting me do it now. Just so much fun. I apologize, everyone.
That's okay. We tested this before, but technology is always like that. When we
How about
see,
now?
no, we see the presenter view as well, the notes.
I don't know why it worked before.
Yeah.
James, do you want me to share your presentation through my screen and then you can have your
let's do
notes
that.
and not, does that work?
Let's do that. I
Okay.
apologize. Sorry.
No,
That's okay. Thank you.
all right.
Perfect.
Can everybody see that?
All right. All right. Well, thanks again. Sorry about the technical difficulties there. So thanks for coming out today. So this summer, I worked with Ambient Intelligence, which is an early stage startup company currently focusing on technology solutions for nursing homes and long-term care. Long-term care holds a special place for me, as much of my career as a pharmacist has been spent in nursing homes trying to improve the residents' level of care. So this was a really important kind of project for me to work on. Next slide. So Ambient Intelligence combines software and hardware to create AI-driven improvements to care for nursing home residents. We'll get into the specific offerings in a bit, but I wanted to start with a quick summary. The nursing home space is struggling right now, as you may imagine, with many issues related to COVID, and there really is a true need for improvement in the space. Ambient's main offering at this point is a fall monitoring device, and software is where I focused my research. Right now, there is no clear dominant player in that space, which creates an opportunity for Ambience. In addition, there's been an expansion of reimbursement codes that are utilized for remote monitoring that have been allowed related to COVID that Ambient can leverage. However, Ambient does face several challenges, including several large players in the space that have more resources. Since Ambient technology is still in its early stage, it hasn't had the time to improve its capabilities compared to others. Additionally, long-term care is a challenging place from a reimbursement standpoint, which is why my final recommendation after that is that Ambient started out by targeting the self-pay segment of long-term care, which is predominantly assisted living. I'll go into more detail as we go through the presentation. Next slide. So COVID in nursing homes. So right now, COVID is an incredible challenge within nursing homes. So some estimates put the current death toll at over 900,000 or 90,000 deaths, some up to 100,000 deaths, which would represent a significant portion of all deaths within the United States. However, COVID isn't really the only problem. With so much focus on COVID, other problems have been created as well. There's at least been anecdotal reports of increased morbidity and mortality among all patients within the long-term care space. This is likely related to staff shortages that have existed prior to the pandemic and only worsened. Also, the need to isolate residents. There has been an increase in residents that are also socially isolated, leading to depression and failure to thrive. The pandemic caused CMS to relax its regulations, and as a result, there have been reports of neglect leading to death. The causes of these things are multifactorial, but they highlight the vast need for improvement in care and long-term care. Next slide. So I saw this article on Associated Press a few weeks ago, and I thought that it really highlighted the situation and what's going on right now. I don't want to read it to you, but I'll make a quick summary. Essentially, people are dying outside of COVID. The story highlights several residents, but one in particular, the resident became malnourished when the septic shock from an untreated UTI resulting from poor hygiene maintenance. His son simply said, they stopped taking care of him, they abandoned him. Essentially, this is one of the big problems right now. Patients aren't being monitored well enough to detect these types of decline and signs that there is a problem. That's where Ambient is helping to make a difference. Next slide. So Ambient's monitoring solution is this. Ambient has built a monitoring platform for nursing homes that utilizes software accessible on a computer or tablet. It combines the use of computer vision and a wearable sensor, currently in the form of an Apple Watch, with the ability to expand to other platforms as well. This allows for continuous monitoring of at-risk patients within a nursing home. Next slide. So the advantages of the Ambient platform is that they take a device agnostic approach. So as a result, it has the ability to expand capabilities to additional monitoring while keeping costs low for the nursing home and also for Ambient. It can monitor residents' vitals and general movement, which is useful in helping to detect subtle changes over time that may signal a warning sign for patients' functional decline. With a single platform approach, alerts can be minimized to prevent alert fatigue for the nursing home staff. Next slide. So potential use cases are, so Ambient is exploring several different use cases. The first to be developed is the fall monitoring. This is where I spent most of my research, since the rest of the use cases are yet to be built out. However, uses could be potentially include real-time monitoring of vitals, such as heart rate, weight, and EKG. The computer vision allows for the AI to detect changes in behavior that can potentially be used in depression screening, which is a huge concern right now as nursing home residents are isolated. In addition, for those patients that are bedbound or do have changes in behavior, computer vision can monitor to see if residents are moving or being moved enough to prevent bed sores, which are a chronic concern in nursing homes. Wearable sensor could potentially be used as a means to detect and record residents who have been in contact with others to help control the spread of infection, which is currently and has always been a concern within nursing homes. This use case is definitely pressing right now with COVID, and just last week, HHS released a program that would share $523 billion in incentive payments tied to infection control. Next slide. From here on out, we will focus on falls. So why are falls such a huge concern in the nursing home? Well, the reality is that falls are one of the main contributors to increasing morbidity and mortality within nursing homes. They account for up to 20% of all nursing home deaths, are the leading cause of injury among older adults. Falls result in many different types of injuries, ranging from head injuries, hip fractures, and broken bones. 1 out of 5 falls results in a serious injury. Yearly, there are 3 million visits to the ER, causing 800,000 admissions per year. It is estimated that this results in $50 billion in direct costs, with an average of cost of $30,000 per admission. And interestingly enough, the death rate from falls has actually increased since 2007 by 30%, from 46 deaths per 100,000 to 62 deaths per 100,000 in 2016. This is likely related to the increasing age of the population. All right, next slide. So what causes falls? Falls are often multifactorial, ranging from things in the environment, physical factors, and cognitive effects. For example, a patient with Alzheimer's has a stroke. However, due to the Alzheimer's, they can't remember or understand why they can't stand up. In addition, the resident is heavily medicated with several medications that make them drowsy. So the patient attempts to stand and then trips over their wheelchair because they have weakness in their left side and they're too confused or tired to be able to reason that the standing is unsafe. I personally witnessed events like this on several scenarios. Next slide. So Ambience fall monitoring capability combines AI, wearable sensors, and computer vision to monitor patients and send real-time alerts to nursing home staff when a fall occurs. This helps to improve care by allowing nursing home staff to focus on other more productive care activities. Currently, staff must make rounds to check on patients or listen for a patient to call for help or push the call light. However, this can be problematic if patients do not have the cognitive abilities to do so or have been injured to the point where they are not able to reach the call light or call for help. As a result, the current system generally result in patients laying on the ground for a significant period of time if the fall is not observed. The AI component of Ambience offering, as more data is fed into the system, the AI can learn to be more and more predictive of falls and try and prevent them before they occur. Next slide. So fall monitoring is considered a low-risk device by the FDA. And as a result, it's considered a Class 1 device. This makes it not subject to FDA clearance, which decreases the regulatory burden for Ambient. The device is only subject to general controls that require compliance with good manufacturing practices, adverse events reporting to the FDA, and registration of the device to the FDA as well. Okay, next slide. All right, there are several other competitors in the fall monitoring space for nursing homes. 2 of the largest companies being Philips and Stanley Healthcare. In addition, there are some other startups as well. namely SafelyU and CarePredict. Most of the current offerings utilize either wearable device or a visual camera, whereas Ambient combines both. It does not seem that most of the players are. It seems that most of the other players are targeting assisted living facilities, which I do believe is related to the structural differences in the way the homes operate, which I will discuss later. I was unable to find pricing on most of their services, but it does seem that most of the homes are billed, most of the services are billed directly to the nursing home instead of the patient. One of the interesting offerings from SafelyU is that they offer a clinical team that can watch the video of a fall to suggest how corrective actions. However, there does not seem to be any single company that has control of the market. This may be related to the fact that nursing homes have lagged in the healthcare sector for uptake of computer technology. In my experience, I've been to homes within the last few years that still utilize paper charts and are resistant to the use of any computer technology or technology in general. Next page. I'd like to take a moment and go over the payment landscape of long-term care, as it's quite complex. There are two levels of care from within what most people consider to be a nursing home. Assisted living, it provides help with basic levels of activities of daily living. I might refer to that as ADLs from here on out. And potentially, they may also provide medication management. Residents typically need only a basic level of care and do not need round-the-clock services and are able to maintain independence. Within assisted living, the majority of costs to residents in these types of facilities is from out-of-pocket expenses, with a small percentage relying on Medicaid. Whereas skilled care is the most complex and takes patients that need significant around-the-clock care. Residents may need help with all their ADLs, medication management, in-house therapies, and additional services. It can be further broken into short stay patients and long-term care. Short stay is paid for by private insurance and also by Medicare Part A coverage, which is further broken down into regular Medicare and Medicare Advantage. Long-term care portion, those patients who are staying longer than 100 days, is not covered by Medicare. Yet there are some innovative models within that space as well. Accountable care organizations, or ACOs, and institutional special needs plans. Essentially, these are something of a value-based care approach that allows providers to profit from reducing costs of care. I could probably spend the entire presentation on the differences here, but the reality is that the majority of payers in long-term care are either Medicare or Medicaid. This is important to note because it explains a lot about why the landscape is what it is. Next slide. So payment differences between the two payers are substantial. Traditional fee-for-service Medicare rates pay $523 per day versus an average of $214 per day for Medicaid. As of the third quarter of 2019, Medicaid hit the highest rate of reimbursement for nursing home days of 67.6%. The most recent data from 2018 shows that the standalone skilled facilities, the total operating margin from all payers was negative at 0.3% negative, compared to an estimated margin of 38% for assisted living, which is predominantly a self-pay industry. This likely explains the loss of skilled facilities since 2009, whereas there's been a growth of skilled assisted living facilities. There are currently around 1,300 skilled facilities in the US and over 30,000 assisted living facilities today. The biggest takeaway here is that skilled facilities are struggling, whereas assisted living is a growing and thriving industry. Next slide. All right. A big portion of my research was spent on helping Ambient to determine a payment strategy. There are at least two options. The first being to sell directly to facilities as a service. One of the structural realities of the software is that you can't really have multiple systems within a nursing home where one patient is using one system and another patient another. As a result, there's the rationale to sell directly to the facility, where they can either pay on a per patient basis or on a fixed cost basis. This allows for rollout to the entire facility and improves the functionality of Ambience offering. However, due to the results of the finances of many of the skilled facilities, this is likely to be a challenge since the margins are not there. As a result, assisted living facilities would be the prime target. Next slide. The second option is to try to utilize remote monitoring codes to bill Medicare and Medicaid. There are several potential codes that could be utilized, but the reimbursement would only really add up to around $90 per patient for the first two CPT codes I have listed here, plus potential to share for the last code. This is contingent on the payers being willing to pay for the service, but could be additional revenue service for the providers that work at the home. The pandemic has caused the usage of these and expansion of codes like this, and there's a a lot of conjecture that that codes like this are going to be much more heavily utilized in the future. Next slide. All right. So my final recommendation for the strategy is for Ambient to pursue assisted living facilities. There's simply more of them for one, and the market is very healthy. Since assisted living facility is predominantly a self-pay industry, facilities can directly pass costs on to the residents for use of technology, can use it to market, and they can also use it to market themselves to potential residents. This avoids the need to deal with complicated billing to Medicare and Medicaid, and improves cash flow since payment terms for Medicare and Medicaid can be long. Once Ambient has additional data to prove its claims or adds additional capabilities, it can target skilled facilities that are within an accountable care organization or an institutional special needs plan by demonstrating the cost savings through reduced falls or other outcomes based on its capabilities. From here on out, I'll take any questions, and that concludes my presentation. Thank you very much.
Thank you so much, James. So we have one question in the chat. First of all, please, audience, send us questions that you would like me to ask James. But there's one question, and you kind of answered this, James, but if you wanted to maybe give a broader answer now. So it's coming from Anshul. Nursing homes are often paid by Medicare or Medicaid. Will the cost of this technology be covered? Also, how would this effect require the staffing ratios? Homes need to recoup their cost of system implementation and use, including extra units for use when the Apple Watches are being charged. And a follow-up question from Anne is that, noting that ALF and SNF staffing is often set by law and or union contracts.
Yeah, so that's kind of the reason why I think my initial recommendation is to focus on assisted living. Assisted living is far less regulated than a skilled facility, and right now, I mean, it is questionable whether this would be paid directly by Medicare or Medicaid. So by targeting assisted facilities, you can essentially assisted facilities often will charge for additional services. So essentially, you can come to a resident or their family and say, hey, we have this technology that what we can do is we can monitor the patient, your loved one, to make sure that they haven't fallen, that can make sure that they're getting an additional level of care that is constant. You'd be able to go online and check on their status and things like that. Whereas, so you could pass those costs on directly to the patient. Within a skilled facility, you're right. I don't see a ton of reimbursement there. However, the real value is the potential decrease in costs, assuming that Ambient is able to reduce falls. In addition, it expands the capabilities and just makes the nursing staff more efficient, so they can really focus on other things. So that's kind of the thing. It's really an augmentation for the skilled facilities, but it is as of right now, I think it'd be a difficult position just because I'm not sure how much reimbursement there would be from Medicare or Medicaid, especially Medicaid.
Yeah. So I mean, that's great. Actually, it's a great segue. You know, you responded on the cost. There's a great segue to another question, which is, have you been looking at the impact of these interventions on the quality measures for the skilled nursing facility quality reporting program? And this question comes from Don Casey, and he provided a link, and he offered to follow up more if you would like on this question.
Sure. Yeah, I'm trying to see it.
I don't know if you are able to see it, but you want me to read the question again?
Sure.
So basically, what is the impact? Have you thought about the impact of these interventions on the quality measures for the skilled nursing facility quality reporting program?
Yeah. So I think, I mean, especially when you're able to really one of the big things right now is like the lack of, there's a ton of documentation that is normally needed. The pandemic has relaxed some of those requirements right now for documentation. However, in normal times, there is an extensive amount of documentation that is done. And personally, I know that oftentimes the documentation isn't really done accurately. So the idea that you could have essentially some of this stuff be automated by providing continuous monitoring, so you can have actual proof. So I've seen facilities be cited during their they call them surveys, which essentially it's an audit of the actual level of care. So I think there would be a potential to save money there as well by reducing costs from penalties, really.
Okay. One more question, touching on liability issues that's coming from Elzbieta Haftek. Wouldn't adoption rate be hindered by liability issues if someone might not want to deal with the technology that can potentially find shortcomings in care provided by facilities?
Yeah, that is, I would say there would definitely be facilities that are going to be like that. As a pharmacist, I've worked in facilities where they, unfortunately, the goal is to document as little as possible so that they can't find things. However, I'm going to say from a less cynical standpoint that majority of facilities want to provide good care. So I think there will be subsets that might have that issue. However, Safely U has actually teamed up with a liability insurance provider to decrease liability costs. Basically being, if you were able to reduce the level of falls, then you can reduce the liability cost to that facility. Because right now, the liability costs are quite substantial. I didn't really go into that in the presentation, just because of time reasons, but there are potentials there to actually save additional costs to the facility by reducing their liability costs by using a service like this, by proving that they can reduce falls.
Well, thank you so much, James, for your work and for your presentation, and really happy to hear about this and learn more about this work. I wanted to wrap your presentation up with a reflection from your mentor, Paul Hines. You know, Paul, we introduced you in the beginning. You're such an engaged member of the MILI community. While you were a student through the MILISA board, MILI Fellows, and now through the board of the MILI affiliates, could you just reflect a little bit about this work with James and in this pandemic world?
Yeah. Thank you, Pinar, and James, great work, by the way. I think this whole year's been somewhat of a mystery for us, keeping us, on our toes on, what the new normal is, and how we need to be elusive and adapt at times. But working with James was pretty straightforward. I mean, it was a very fluid relationship. We had set calendar meetings every week to update progress, share new insights, and talk about technology, which eventually leads to talking about life. So what Brian in Ambient is working on is an extremely novel concept, and he's actually, when James was working closely with Brian this summer, Brian was actually going through the G-Beta accelerator at the same time. So there was just tons of new information coming at us from every which direction. New insights from James, new insights from Brian, new insights from G-Beta, and just industry collaborators as well. So it was a lot of fun. It was a lot of fun, and I'm happy James was able to jump on board for the summer, because I think his expertise in the long-term care space, especially within being a pharmacist, provides a really unique perspective, especially from the business side, because we have an idea of what pharmacists do, but CVS isn't a long-term care facility. And so he brought a lot of really valuable insights and just brought a lot of hunger as well to reach out to the broader MILI community to answer questions that we didn't have answers to. So it was a really successful event.
Well, thank you for both so much, and your organization, Paul, as well, to basically engage with us in this research effort as well. Thank you.
Yeah, you're very welcome.
Okay, well, we have our next speaker, Arijit Chanda. He's a full-time MBA, and this summer Arijit worked with the Rollback Medical Devices Center in our University of Minnesota World, MDC, on MedWorks, development of virtual reality-based implementation. And basically with COVID-19 forcing schools to go online, there's this increased need for medical programs to adopt virtual reality instead of cadaver for teaching anatomy. So we look forward to hearing from Arijit and his presentation. Just a brief background on Arijit. He's a second-year full-time MBA student specializing in strategy and technology. He has an undergraduate degree in computer science and engineering, and he has pre-MBA work experience, 5 years in the software industry, started as a software developer with Infosys and worked most recently as a technology strategy consultant with Oracle. And Arijit is mentored by Paul Rothweiler of the MDC, and Paul has incredibly long 30 plus years experience in the industry, ranging from Fortune 500 to consulting firms and startups, and every position in a company from research, manufacturing, M&A, IP management, organizational design to sales and marketing, every level from researcher to vice president, and he's a forte in product development, business development. And he's currently working at the University of Minnesota's EBAC and Medical Devices Center as prototyping and materials coordinator, and MedWorks and academy leads. And just on a personal note as well, Paul is another very, very engaged, I will call you a MILI community member, Paul, because every time I have any question, Paul is there right away to help us out, answer questions, connect people. So thank you so much for that. So Arijit, do you want to take the
Yeah, definitely. So thanks for the wonderful introduction, Pinar. That's been really helpful. Just a moment, I'm trying to, just a moment. Why don't I get my PPT? Yeah, so I'll just be sharing some of the work that I did this summer, and it's been really exciting. Okay, so first of all, good afternoon, everyone, and thanks for tuning in. I think it's pretty unusual to spend your Friday afternoon listening to our work, but I really appreciate the time and the effort behind that. So my work was, as Pinar said, was around MedWorks. And so when I first met Paul, he basically asked three things. Where are we? We know that we create value, but where are we? The second question was that where could we go from here? And the third one was around how can we increase our users. So I would be covering the first two as a part of this presentation. So just to give you a brief executive summary, so COVID has been a really difficult time for all of us, but I would argue it's made MedWorks much more valuable based on the offerings that it has. So, I mean, we have seen that virtualization has actually evolved from an augmenting experience to a more necessary part of the medical education. The virtual reality or the mixed reality based systems is much more cost effective and hassle free. And we have seen that that has prompted many medical schools to go completely online, as well as augment some of the classroom experience with these applications. And then the other thing that we saw was that while there were like many other competitors or firms which were providing services similar to MedWorks, so MedWorks had a great competitive advantage over them, solely based on the facts that the range of capabilities that MedWorks has, it can provide an end-to-end experience based on that. And then the last point here is on the recommendation that I had for Paul, one of the recommendations that I had for Paul, and that was to organize based on the functional competencies to serve to the user more directly. So cool. So I think that's a lot of content. So just to jump into some of the fun things. So MedWorks is this really cool institution within the Medical Devices Center. And as you see, the MedWorks moniker spans 4 core pillars. So we have the virtualization, the segmentation, 3D printing, and the CAD. And just like a side note, all of the pictures that I have shared here are from actual projects done by MedWorks. So I think that makes it even more cool. And so each of the projects of MedWorks encompass one or more of these areas, and I'll be diving deep into some of these. So starting off with the virtualization. So, I mean, all of us are pretty familiar with virtual reality or VR-based application. So what I want to touch upon are some of the applications in medical science. So we see that in simulation, in virtual reality exposure therapy, pain distraction, diagnostics, rehabilitation. And on the bottom left corner, so I've tried to like put in the VR healthcare market size. And this was from a report done in 2019. So it doesn't capture the COVID impact, which I think has made the VR a much more valuable. And on the right, we see a patent file. So the trend that I want to point out here is that, so we see that this market is very valuable, it's growing, and we also correspondingly see an increase in the number of research. Moving on to segmentation. Medical image segmentation is the process of automatic or semi-automatic detection of boundaries within a 2D or 3D image. And how it is used in medical science is through the visualization of anatomy, diagnostics, demonstrations, etc. And similarly with the virtualization, if you see that the medical image market is growing and it's expected to grow even more, and correspondingly the interest around research has also grown over the year. And just a call out here, the 20 numbers include as of July 2020. So I think the number would also increase post that. And finally, the other segment that MedWorks caters to is the 3D printing and CAD. So I think most of us are familiar with 3D printing. So I'll talk about CAD. CAD is the use of computer to aid in the creation, modification, analysis, or optimization of a design. And how it is really utilized in medical science is through tissue and organ fabrication, implants, prosthetics, anatomical models, surgical tools, etc. And as with virtualization and segmentation, we see that this trend continues in 3D printing. So it's very valuable now, it's expected to grow, and there's a considerable research interest in 3D printing. So yeah, now moving on to the most interesting area. So the first question was that how does MedWorks creates value? And my research identified that there are 4 areas where MedWorks creates the most value. So I have listed them on the left, and in the middle we have the uses, and then the KPIs on the right. So the first and the foremost is anatomy visualization. So some of the uses of that is like on-demand remote learning, research, resident training. So you can visualize that as an augmented or a supplemented classroom experience. And some of the KPIs for that would be user feedback, the accuracy of the structure that is constructed, the cost of maintenance, etc. And then the second important area where MedWorks creates a great deal of value is medical device design. So we know that, I mean, it takes a lot of time and effort to create prototypes. So MedWorks offerings actually helps to make this process faster, and it reduces a lot of time as well as waste in this process, because that's also one of the areas, one of the byproducts of these rapid prototypes. And like some of the other uses of this would be like to complement some of the existing medical devices or existing structures which is there, to demonstrate to customers. So that is something that we don't often see. Like for medical devices, we usually see manuals or like other online articles. But I mean, some of the ways that it can be very useful is actually providing as a platform for demonstration. The third area is on pre-surgery planning. So MedWorks provides the capabilities to practice complicated novel surgeries. And I'll talk about one of the examples later. And then I think the second important area would be to educate teams or new surgeons, etc., on some of the best practices of surgery, etc., and also on capacity planning. So that's an area where this can be really useful in the operation theater. And then the last area would be around teaching and demonstration as a part of the curricular pedagogy or online remote learning, or even to demonstrate to patients on the surgeries that they're going to about to take, or make significant medical decisions around what to opt for, as well as insurers. So with that, I'll move on to some of the use cases that some of the uses that MedWorks presently does. So presently, as you see, so most of MedWorks' offerings are used within the UMN ecosystem. So the most significant user group would be the surgeons or the doctors and the clinicians. So they primarily use the VR and the 3D model for pre-surgery planning. And one of the cases has been a very successful operation of the conjoined twins, which the medical school performed based on some of the like models from created by MedWorks. So they actually simulated this experience before, practiced on that, and then performed the actual operation. And some of the other areas around that are these orphan cases where MedWorks manufactures this like on a requirement basis. Like recently, so we have been doing this, the eye socket expander, and Paul can talk more about that at the end. Yeah. So, and the way the clinicians use is mostly segmentation of the CD scans and the visualization of these scans through the VR system that MedWorks has. It is also used by medical professors within the UMN ecosystem through 3D printing prototypes for classroom demonstrations, etc. We have had students use the services for some of their projects that they are working on, etc. And lastly, we have also seen a lot of medical device companies, even outside, outside the UMN ecosystem, who have utilized our services for the rapid development and testing of these medical device prototypes. Now, based on the values that MedWorks created, we could identify a lot of other significant use cases that MedWorks can cater to. I've listed some of them, and I would like to highlight some of the interesting ones. So one of the most interesting things that we found would be using VR and the other capabilities in prosthetics. Because as you know, like for patients utilizing who have to resort to prosthetics, it's an extended part of their body, and we often see that. So there's a lot of like wastage around prosthetics because certain parts doesn't fit, or it doesn't cater to the emotional side of the patient. So so we think that that's really valuable to give them a simulated experience to understand how those parts would look like. Some of the other interesting examples would be utilization in the fitness industry. Like, I mean, we see a lot of the fitness videos and other online stuff, especially in the post-COVID world. And one of the interesting, cool things that MedWorks can do is actually like portray some of the underlying body movements. So that can be one of the other areas. And then the other place that this can be actually utilized more would be in educational institutions, as in the form of like interactive VR-based courses and assessments. So with that, I would move on to some of the companies that we have studied as a part of this study, and to see where they belong. So I've tried to map that on a 2x2 to see where they stand. And so on the y-axis, you see the similarity to MedWorks, and by similarity, I mean like how closely they align with the services that MedWorks provides. And on the x-axis, you see like whether they own the product or not. So one thing to call out here is that MedWorks, it has licenses for many of the products, and it also uses Unity, which is an open source product, to create the visualization softwares. So based on that, I came up with, so I placed the companies that I studied under these three buckets. And in the next section, I would like to talk about three of these companies falling in each of this bucket. So I would start off with Anatomich. So Anatomich is probably the ones closest to MedWorks. And as you see, I've listed the revenue numbers, which at this point may not be very valuable to us, but it gives us an idea of the value that we are creating. And then, so they primarily cater to a B2B and a B, like to business to business as well as business to consumer, and they're in medical imaging. It was founded in 2004, and it develops and provides medical instruments, and it has the Anatomich table, which is the only fully segmented real human 3D anatomy systems. So you can think of that as an alternative to the physical cadaver. You can think about the Anatomich table as an alternative to the physical cadaver, some of the capabilities that it utilizes is virtualization, segmentation, 3D printing, and we anticipate CAD, though it's not explicitly clear from their offerings. And here I've listed the targets audience for them. So the target audience is the medical students, medical institutions, doctors, and clinicians. So the reason I thought of highlighting this is that Anatomich table can be a very useful tool for MedWorks to come up with something similar, because we do a lot of these activities in isolation, in like where we help to visualize different body parts, but not as a complete entity as of now. So this can be a good reference point. Now, moving on, the next example is from the lower right quadrant. So it's a company called Lighthouse, and it was founded in Stanford in 2013. And it was founded through the Stanford Virtual Heart, which was a virtual reality simulation of the human heart. And then it also expanded to a few of the other products, and it was mentioned as one of the most exciting projects of the year by Mark Zuckerberg in the Oculus Connect in 2017. So one of the key differences with what we offer versus Lighthouse is that, I mean, it doesn't have any provisions for 3D printing. So that can, I mean, be a huge differentiator, for us. And the target audience is pretty much the same. So the reason of listing a Lighthouse is that it's a very good model to study about these specific functions. Like as we zoom into some of the more specific VR functions on specific parts of the body, this is a reference that we can look at. Then moving on to the Case Western School of Medicine, Case Western Reserve University School of Medicine. So in 2016, CWRU and Cleveland Clinic released this application called Holo Anatomy, which was the first third-party app in the Microsoft HoloLens store. And the reason why I thought of pointing that out in the research is that it actually helped the first years to go fully remote, for the first years of the medical school to go fully remote. So this is one of the like areas that MedWorks can look into, and probably a model that they can utilize to help the UMN medical school transition to a more online seamless model. Now, moving on, so I think that the key takeaway from looking into these organizations was that MedWorks is in a unique position because it has all the 4 capabilities to provide more end-to-end products and solutions. And the second thing, which was like not very explicit from the way MedWorks is positioned right now, is the range of capabilities that it has. So the second thing was like MedWorks needed to organize sometime in the future to make its offerings much more explicit. And so essentially the next step was to reorganize and to determine what was the value proposition of each component. So based on what we learned, so the suggestion was that we have 4 different like we organize around 4 different areas. The first one being the MedWorks Virtual Anatomy Lab, the second one being the MedWorks Online Learning and Interactive System, the third one being the MedWorks External R&D, and the fourth being the MedWorks Solution. So and so I think the rationale behind that and behind like visualizing about how we would organize was first of all, like a greater part of our users were within the UMN ecosystem. And also as a part of the UMN, we had the moral responsibility of catering to UMN's needs before we do create some products for the rest of the world. So I tried to place this on a 2x2. On the left, you see the user type, whether they're within the UMN or outside. And on the x-axis, you see whether the nature of the project is proactive or reactive. And the reason is that like few of these capabilities would require long-term development. And also the fact that we have to rely a lot on our incoming students. So some of it has to be continuous. So that was the rationale behind putting it like that. So let me just, okay. So yeah, I hope I have some time. Sorry. So based on that,
we're very short in time. I don't know if you would like to wrap up and maybe we'll ask one question.
Okay, sure. So I'll just wrap up in a minute by introducing each of these. And so sorry, I mean, I very excited when I talk about the project. So the virtual anatomy lab. So I think the basic, the main value proposition of it would be to transition into the online world, to transition into a world beyond cadavers. So we know that nothing replaces an actual cadaver performing an operation there, but that is the real value proposition. We have a clear competitor in Anatomich here. In terms of online learning and interactive systems, so this is more of an online on-demand learning and evaluation platform. And so we were discussing the last day with Paul that, I mean, so a lot of people take these courses, I mean, as a part of enhancing their education as well as a part of the curriculum. So this can actually be maybe in the future become a part of the curriculum as well. And then the external R&D, so this is much more focused on what Medworks is actually doing right now. It's actually working with the medical device companies. And so the key differentiator here would be that it utilizes the innovation collaboration, which is Medworks, as well as the greater University of Minnesota's expertise and resources. And then I've proposed the catch-all Medworks solutions bucket, wherein any innovator, any developer can come in with their idea, and we can help them visualize how that would look like. So with that, I would come to thank all the wonderful sponsors, as well as my mentor, Paul, who has been absolutely fantastic to enhance my understanding of everything. So like, yeah, thank you, Paul, thanks, Pinar, and thanks, Jessica. And also, and I also want to acknowledge the subject matter experts. So these are the people on the ground. These are the people doing the wonderful work that you have seen through the rest of my presentation. So thank you to all of you. And with that, I'll end.
Thank you, Arijit. Thank you so much. So there is one general question. You know, it's not directly maybe related to what you were doing, but you know, given the team and their work during the summer, maybe this question came up. So this is from Don Casey. How is VR being deployed and developed and deployed to reduce and address racial bias in medical education? Have you guys been thinking about it in the context of Medworks?
I mean, I don't have a quick answer to that because we haven't, I mean, thought about that directly. We were more thinking about that as an application perspective. But I mean, I would lean on Paul to see what he thinks.
Yeah.
You know, I got to admit, you blindsided me. You know, we've been very busy in building these capabilities and working with these people, and we're very blessed. It was, we were at one point, we were being contacted by clinicians maybe once a month. Now they're contacting us once a week, sometimes twice. So we've been very busy and thank you for sending us Arijit, because he was the right guy at the right time. He had the software background, he had the business strategy background. And so there's a lot of work, as you can tell. We found out we had a capability. Now we've got to make it so it's a viable, really business, because everything is business at one level or another. We have to make sure that we can continue to fund our research and to develop this capability. And that's going to take money. And that's going to mean paying attention to the customers. And that,
yeah, I mean, I think it's interesting to, like, you can bring this question back to the team. I would be very curious to think about it too, in how exactly. There's another one little comment for Medworks. This is from Ananta Santanam. Last year, Joe Letterman approached me for a VOC interview for UMN Health's new cardiac training and consultation service offering. I'm not sure where that went, but Medworks could partner up with that program, offer 3D printed models for anatomy training, create VR experiences for preoperative planning, anatomical modeling for intraoperative visualization. Thank you, Ananta, for that suggestion, and I'll leave Paul and Arijit to take it back to the team, I guess.
Well, actually, it's funny. We are doing that today. We're doing that with the vet school, and we are also doing it. There's a former University of Minnesota professor, good friend, who started up a company, and he is basically doing that to train surgeons on his medical device. So he will send us the patient files. We'll provide him a visual as well as a print, so the clinician can basically practice the surgery before. But it's kind of the same thing. It's educating the physician, it's educating the patient on what's about to happen to them. So yeah, I think we should talk with him.
Thank you. Thank you so much. Okay. And then Ananta just said the med device companies are spending a lot on field sales training. So that's probably something for you to consider as well.
Definitely. Yes. Okay.
Well, our third speaker, Matt Stanovich, also mentored by Paul at the MDC. Introduction to Matt. He is a member of the Carlson full-time MBA class of 2021. Matt holds a business administration degree from Wisconsin Lutheran College and a Master of Science in Finance from the University of Missouri. He has worked in the commercial banking and investment management spaces, where he completed equity research and merger planning and integration. In 2015, Matt enlisted as an infantryman in the U.S. Army and was subsequently stationed at Fort Riley, Kansas, and Camp Casey, South Korea, as a team and section leader. At Carlson, Matt has focused his studies on corporate finance, strategic management, and is pursuing a MILI specialization. Following graduation, Matt will join Cigna's financial development program at the St. Louis office. Well, thank you, Matt, for being part of this program and for your service to the country in general as well. And please present what you have discovered this summer.
Great, thank you, Pinar, thank you. Let me get this out of here. Thanks for your time today, and thank you to everyone in our audience. It's a great introduction, and as Pinar said, I also had the pleasure to work with Paul. And as someone transitioning from very much a non-medical, non-healthcare background, it was a real pleasure to work with someone who's had experience in some of those business roles as well as the medical side. And so looking at a bit of what we'll talk about today, I am going to keep this very high level. This project that I worked on and collaborated with Paul and the Bach and MDC is still an ongoing project, still relatively early in development. So I don't want to give away the secret sauce, if you will. But I do want to talk a lot about the problem that it's intending to solve, and maybe how that's received in the marketplace. And to really quickly kind of set the stage on that, I know that we've been living through COVID for a long time now, but I joined this project around the 1st of June, and that last month or two before June, we really started to see hospitalization rates climbing just really precipitously, as you can see in that boxed area on the figure from the hospitalization tracking project. And so it's actually kind of interesting how this project started at the Bakken Medical Devices Center. And no, it's not the co-venture on the right, but that is something that I just want to highlight how active the Bach and MDC, as well as the rest of the university, has been throughout COVID. And I think that's one of the great benefits of going to a research university like the University of Minnesota. And so dirty phone cases, copper pennies, and how does that lead to a product? Well, I was just talking with Paul the other day about kind of how this project came to be, and he recalled how some time ago he was thinking about how filthy phone cases were, and thought, you know, is there a case here where we could make an antimicrobial case, and would it be cost effective? And he kind of determined no, unless you were gonna, you know, model it as a Gucci or Prada or something. But then throughout this ongoing COVID crisis, sometime later, kind of still having that thought in the back of his mind, remembered hearing kind of an interesting fact about pennies and why they're made of copper and how they have these antiviral, antimicrobial properties, and that kind of sparked an interest. You know, can we replace commodity items with a plastic impregnated with copper, particularly in hospitals, in an attempt to reduce viral transmission? And so that's where this idea kind of started, and I kind of called this project Biocidal Thermoplastics, and that's kind of been developed through a lot of VOC, voice of the customer work. But for me, when I was given this opportunity to join the team in June, for me, it was an immediate yes, after having a discussion with Paul and seeing what timely, impactful work this was, as well as going to Carlson to do my MBA after the military. I was really doing that, having a master's in finance to gain those cross-functional skills. And so to work with someone like Paul and have the opportunity to try to develop some marketing and strategy initiatives was really appealing to me. And so anyone, and I know when I looked at the audience, there's several MILI fellows on, several graduates and affiliates. I kind of modeled this to be a valuation lab type project, having not gone through the valuation lab before. I'm actually currently in the Palo Alto one, and so that's kind of how I frame this. It basically, is there an investable opportunity here, given that it's so early in the project? And so I after project kickoff with Paul, I kind of had this initial question that we discussed: would hospitals be willing to buy more expensive equipment if it reduces transmission? And there's a whole lot of sub questions that go to that. And so I really kind of divided my work into these 5 buckets, obviously nowhere near as linear as they're presented with the arrows there, but most of the work that I did and the value that I thought I could add fell into those research and market assessment buckets, really determining, is there actually a market here? How long, is this a permanent market opportunity? Can we monetize this and recover our costs? And then, you know, that market assessment side with voice of the customer, clinical relevance, that was the biggest part of this project, was starting with clinical research. It was important for me to understand what had been established in scientific literature, how the medical community had received that, and then listening to the customers at various points throughout the value chain, to try to determine, is this something that we can do? Is this something that the Bach and MDC should continue to pursue? And so I kind of started with this early thought that, yeah, safety's got to be the #1 priority. They're going to value these time and cost savings, and licensing might be the best opportunity here. And so, again, this is just going to be a very brief overview of these areas, but I started with the IP. That's kind of where Paul directed me to start. I'm glad he did. It provided an overview of how we might protect the technology package, as well as kind of created an early alert system for me at who's out there already in the marketplace looking at these same things. And so anyone who's done it knows this is a really time-consuming process. But I think I was able to provide a picture of the 3 main parties that are responsible for the handful of related patents currently out there in applications, so that I could describe kind of the state of the art and provide that overall opinion that, yes, I do think there's an IP avenue available, but it's of course going to be dependent on novelty, and that would be determined by the interaction between the biocidal agent, this metal, this copper that we're looking at, and then the thermoplastic, as the patents currently out there are relatively direct or specific in their claims. And so then, you know, there is at least one small direct competitor who hasn't monetized yet, is still conducting pre-commercialization activities. So that was important, and that allowed us to see some of the things that they're doing, and learn from that. And there are many indirect competitors. There's a lot of alternative products that try to do some of what this product wants to do, but I would argue they're far inferior solutions. Regulatory, I didn't spend a whole lot of time on because we had kind of thought from the beginning that licensing would be the route to go. And considering, you know, most of the applications of this technology package is how I kind of refer to it. Most of the applications would be likely class 1 or 2, 510K exempt. There are, of course, general standards. There's these recognized consensus standards there that, you know, that in addition to the cost of insourcing design and manufacture of medical devices, it seemed clear to me that licensing was in fact the way to go. It's also important to consider the EPA here. This is something that I learned a little bit later down the road as far as the EPA approving registration of a few specific claims in 2008. And so only one of them is listed on the screen regarding continuously killing greater than 99.9% of MRSA within 2 hours of contact. But these were great for us to kind of frame, okay, from the efficacy side of this product, what do we need to prove? What's already out there, and how do we compete and communicate that value to the market? The clinical relevance stage was probably one of the largest stages here. And one of the key findings early in my research beyond COVID was actually that about 1 in 31 hospital patients will get a healthcare associated infection, an HAI. And that has a huge toll, both in terms of deaths and costs. And you see that range is very drastic. And that's because of the amount of assumptions that really go into that indirect societal cost. So from this, I felt that there was an economic case to be made, and I dived kind of deep into that into my white paper that accompanied this report. But then you also have to think, can we prevent these things? Have there been studies to show that these are preventable? And there's actually a 2020 meta-analysis by Fenn and colleagues that suggests that about 35 to 55% are reasonably preventable with current strategies and pipeline technologies. And this, you know, the CDC in 2009 released an estimate that about a third are preventable. And so there was just a wealth of estimates kind of in that 30 to 50% range of preventability, reasonable preventability. And so again, I thought that this really started to tell the story of the economic benefit of this product. The scientific literature on copper goes back thousands of years. It's well known, well studied. One in particular that I point out here is the 2014 Monk study, because it's fairly similar to some of the applications that we had thought about. They tested 2 solid surface countertops that had copper 1 oxide that was used according to EPA protocols, and they found a greater than 99.9% reduction within 2 hours of a handful of pathogens. And I listed a few on this slide that are of importance. But that study also wanted to talk about simulating years of surface abrasion and repeated bacterial loading and these things that became pretty important in the recommendations that I made at the end of the project. So, you know, there's some success factors that I made recommendations of throughout, and these aren't kind of my end ones. But overall, I thought clinically and from what is out there on HAIs and copper, I thought that there was a strong case for adoption, that HAIs are going to continue to be there, costs are continuing to go up, and that this shift in kind of healthcare policy toward quality, transparency, and the future kind of competition, if you will, that hospitals might kind of compete on these metrics, I thought those were all tailwinds for this project. Looking at the market, this is where I spent a lot of my time and probably could add the greatest value. The takeaways here was that time saved was in fact the most important factor across all demographics. Cleaning ease and effectiveness was actually the second most important, and it was the greatest factor for the purchasing managers that I spoke with. And so that kind of helped frame, okay, how do we want to kind of communicate this value message? And also what are some of the claims that we need to potentially prove? The kind of the missing piece to this whole puzzle in my research was the cost effectiveness. Up to this point, I had kind of thought, you know, it seems like there's this great case here. Why is nobody in this space already? And there really is a lack of study on the cost effectiveness of Yeah, as I mentioned at the top of the slide in the VOC, reduction of HAIs is difficult to prove. And so there have been 2 recent studies that I put on the slide here that kind of speak to cost effectiveness out of the UK and one in the US. That is the area where I think there needs to be continued work. And I will say that the small kind of direct competitor who hasn't monetized yet is working in that space through clinical trials. And so to increase the chances of adoption, thinking through what can we do to increase the chance that we see this and really drive that societal value that we think is there. EPA registration is a great one. One of the competitors has done this. It took them about 2 years to do it. That's a long time. So you got to kind of consider, is that worth it or not? Clinical trials too, we saw a lot that were in kind of the 6-month range. So potentially you could be looking at a shorter timeline there. But what was clear throughout the market assessment was that everyone from the physicians to the purchasing managers, the administrators, the manufacturers, they were all relatively familiar with copper. They knew products currently being used for its kind of antiviral, antimicrobial claims. And so in general, if we can kind of stick to this messaging, there's an opportunity here. So kind of wrapping up, and I mentioned at the beginning that this is going to be kind of very high level, and if anyone has questions and Paul wants to dive more specifically, that's great. But ultimately, I do believe that the research that I presented in the white paper supports the claims that this technology can transform those high contact surfaces and kind of the near patient inside the curtain setting into low maintenance transition resistant equipment, and that those will save time and money. And those are things that as this continues to be developed, those are things that you would certainly want to quantify. However, one of the big takeaways, and Paul reminded me of this throughout the 2 presentations before this, reminded me again, is the value added that the University of Minnesota brings to these projects. And when you can call something developed at the University of Minnesota, tested at the Immunology Center, that adds a lot of value. And additionally, there's great partner and collaborator relationships, both whether it's in manufacturing or on the customer end. So ultimately, I recommended that we kind of focus on biocidal as opposed to antimicrobial. Through some studies, they found that customers were more receptive to biocidal, kind of inferring the killing action, not just slowing or inhibiting, but really focusing on that preventing harm with no change for staff or patients is huge to minimize the implementation costs. And so I'm happy to, in kind of conclusion here, to just report that this is still in development. COVID has slowed some of the testing capabilities and processes, but I was very happy to work with Paul on this. I'm hopeful that some of the recommendations I made in the paper will be useful in taking this product to the market. And with that, I am done, and I will exit my share so I can see if there's questions.
Thank you, Matt. Thank you for your presentation. We just have a few more minutes. There is one question from Dylan McMahon. Copper patinas over time, does this oxidization change the effectiveness of the copper in the products?
You want me to take that one?
Yeah.
Well, so, if you want, Paul, I know you're the expert there.
I don't have the answer. It's going to be one of these.
Well, I am a chemist first. I graduated from the University of Minnesota with a chemistry degree. And I always assumed it did have to do with the oxidation state of the copper being more effective, right? Because in my mind's eye, it's like I'm giving credit to the electron pairs that are disrupting the viral membrane or the RNA in its ability to function. It turns out that was a great hypothesis, but literature shows copper 1, copper 2, different oxidation states all have the same functionality. Surprise.
There's one more question from Don Casey. Have you thought about implementing this technology in clinical work areas that are outside patient rooms?
Yeah, so I think we're looking at it, Matt and I, and as well as the rest of the Bakken. We're looking at this as a material that can be used in any article, because what we're proposing is to embed the copper in a thermoplastic. So, for example, you've seen beds that have copper, usually electroplated coatings. That's probably good that bed stays in metal. But things like toilet seats, countertops, even knives, this can be used in all of those applications. And somebody is probably waiting to pounce on me and say, well, plastic's relatively cheap. You're going to add an active ingredient that's going to cause the price of the article to go up. Well, it actually turns out, so most plastics are about on the low end, $1 a pound, $1.30, right? On the high end for some of the engineering plastics are $10 or $11 a pound. Turns out copper is only $2 to $3 a pound, depending upon the spot price. So we're not actually causing the price of the article to increase that dramatically.
Thank you so much to both of you. Paul, do you want to reflect on working with Matt and Arijit, just the entire experience? And then that'll be the wrap up of our event.
Yeah, to both of them, they were great. As Arijit mentioned, he pointed out that he was working with the MedWorks team. He got right in there. You know, they enjoyed working with him. He just bundled himself into the project team as Matt did. It was like, welcome to the team, right? They didn't disrupt us. They aided us. And for that, as you know, we've always appreciated MILI's contributions to the Bakken, particularly yours personally. And we're looking forward to a lot more of this.
That's a great wrap up. Well, thank you to all three of our students and their mentors for this amazing opportunity and really spending your summer in such an incredible way to help contribute knowledge this way. Thank you guys so much. And thank you to the attendees for joining us and listening to our presenters and for your questions too. Thank you so much. Have a nice afternoon, everyone, and a great, great weekend.
Thank
Bye.
you.
Bye. Thank you. Thanks, Paul.
You're welcome.
Thanks, Paul.
Bye. Thank you.